will be a little bit longer than the kudos, but not much, each of us, I suspect. I'm here today on behalf of the American Diabetes Association, actually, and as a clinical researcher. So I kind of am going to take it from the bottom up. You're publishers, and I'm going to show you the journey that it takes. I thought would be interesting for you to get to the point where we have something to publish, and then talk about the impact of these cuts on research funding on what we do as researchers and as a national association advocating for a chronic disease for funding. So long before a publication gets to you, we have to have an idea, and we have to seek funding to generate evidence to put into a manuscript. And so that there is me sitting in the emergency room in my 900-bed hospital that has about 14,000 visits a year for patients with diabetes. This is located just a few miles from here and up the north of the Capitol building, which you may have already seen. And so when I'm in my emergency room thinking about these 14,000 patients with diabetes who come through there each year, I have to focus on a few things. I can't address the whole issue. So when I look at them and see barriers to diabetes care, I see patients who have to juggle many, many things to have a good outcome on a day-to-day basis for their chronic disease. And I find that in my emergency room, about 60% of patients, and nationally, only about 45% of patients have had no education at all in how to manage their disease. So if you think about it, they have to juggle checking sugars, eating foods, taking medications, dealing with side effects of medications, all of those things that need to fit together in a kind of perfect constellation for their blood sugars to come out right. So that's one of the barriers that I've been trying to address in my own institution. Clinical inertia is described as the process whereby medications don't get advanced fast enough. So typically a patient with diabetes is seen by a primary care provider, something's done to their medicines or not, and they're told to come back in 3 months. But that doesn't take into account the fact that intervention may not accomplish what you want with their sugars. And typically a patient with diabetes who has uncontrolled sugars and an A1C diabetes control number over 8 won't get insulin added to their regimen for 5 whole years because those interactions are slow. So that's one of the other barriers we're looking at. And then finally, medication adherence, getting the patient to actually take their medications. Okay, that means they have to get a prescription, they have to take the prescription to be filled, they have to have money to pay the copay, and then they have to understand when to take the medicine and how to take it to avoid the side effects of that medication. So in my emergency room, those are 3 big issues that we have sought to address. And so this started out, my first effort to address it, and I call it survival skills education, was funded by a philanthropic donation through the foundation at my hospital. Using that, we did our first project. We showed that you could convey concise knowledge in a short period of time to the patient and impact their diabetes blood sugar control. We then went out and garnered more support from farmers for what we call Investigator-Initiated Trial. I think of an idea, I write a proposal, I submit it to a pharma, and they provide money for me to do it as an independent researcher. They have no input into it. They're supporting research by giving it to an investigator who has a good idea. Using that money, we generate a little more evidence, and I can go to the District of Columbia Department of Health, and they can allow me to do my first intervention in the emergency room. And with that preliminary data, I go to the American Diabetes Association and receive a core research award that allows me to conduct the randomized controlled trial that will end up as a publication in one of your journals. So that is exactly what we did. We got money to do a randomized controlled trial that we've just recently completed. We went to the emergency room, found patients who came in with blood sugars over 200. We placed ourselves in between the stretchers in the emergency room, started delivering survival skills education, showed them how to take an insulin shot if their sugar was over 300 and they needed to take it. We made them do it right there in front of us in the emergency room so they'd come over the hurdle. And then we brought them back in 12 to 72 hours because the emergency room doctors were afraid that we would cause low blood sugar, which is a safety issue. And then we saw them a couple more times over a 4-week period. And following that, we were able to lower their A1C control number by 1% compared to patients who were randomized to control, which is actually a phenomenal drop in blood glucose in a short period of time. We usually only look at A1C in 3-month increments. So their sugars went from an average of 356 down to 180, which is the upper range of where the Diabetes Association says your sugar should be. So we had a good outcome, and we're going to be presenting this at the American Diabetes Association. So that's a many-year journey to get to a rigorous randomized controlled trial. And so the American Diabetes Association has supported my research, but also supports research for many other investigators, and actually has as their strategic objective for research by the end of 2013 to increase the number of career development awards that they give. If you want to build researchers who will go on to a lifetime of research that will make a difference to clinical management, you need to help develop careers because it's hard to get research funding. And they also actively lobby for federal and state funding for diabetes research. In terms of your kind of metric, when a grant is awarded by the ADA, 6 publications will result from a single research award, and for the career development people, because they're really driving in the direction of building their publications, there'll be even more, and they actually also generate quite a few patents. So investigators leverage this kind of early career support into a 7.5-fold increase in funding. We've looked back over the last 5 years of awards and find that people do go on to successfully receive subsequent funding. So that's kind of the journey of me, the researcher, and I'm not atypical. In terms of the impact of the sequestration, it's very disastrous, as you already heard from Glenn. A fewer number of grants were awarded, and this results in a success rate for people submitting grants to NIH going down from 21% to the frighteningly low level of 14%. So it makes it that much harder to get funding to continue your work. Diabetes serves as a good prototype. My story is similar no matter what field people are working on in chronic diseases. Diabetes is the second most costly disease in terms of financial burden to the healthcare system, next to Alzheimer's, interestingly, in the United States at the moment. And this, makes research in our field particularly important. Research really does make a huge difference. It's led to many advancements and improvements in the treatment of diabetes, including predicting risk of developing type 1 diabetes, the diabetes that typically develops in youth, preventing type 2, which is the epidemic that is sweeping our country and indeed the world as people's lifestyles become less and less healthy, and combating the complications of the disease. Research at NIH is currently supporting development of an artificial pancreas that will regulate all of these aspects of controlling your sugar for the patient and testing medications for type 2. And my final slide just shows you that all of the research that's been going on over the last 2 decades, from 1990 to 2010, and this is an article that was published in the New England Journal just this month, has actually had a marked impact on diabetes complications. And so acute myocardial infarctions down by 67.8%, stroke by 52.7%, amputations by 51.4%, end-stage kidney disease, which means dialysis or transplant, down by almost 30%, and high blood sugar crises down by over 64%. So funding research is critical to improving the health of patients we care for, and in order for us to get that research funded, we do need to publish. So I would make to you the very strong case that research and our ability to publish it makes a huge difference in the health outcomes for